Assalamu alaikum. This is second lecture inshallah. In this course we'll talk about physiological adaptations during pregnancy. Our objectives: to discuss physiological and anatomical changes of pregnancy, interpret these changes' effect upon pregnancy, birth and puerperian period. Last, to understand the physiology of lactation. As an introduction, we know pregnancy have anatomical, physiological and biochemical changes designed to meet the demand of mother and developing fetus and the birth process. Unless understood, will misinterpret it as pathological change. First, we'll talk about cutaneous change. Cutaneous change: pigmentation occurs in pregnancy, probably due to melanocyte stimulation hormone, which is a peptide hormone mainly secreted by pituitary glands, and in pregnancy may be produced by the placenta. Other hormones involved in this pigmentation: estrogen and progesterone, which is supported by similar changes occur in patients taking oral contraceptive pills. This pigmentation is self-limiting, disappears after delivery, has no effect in pregnancy apart of cosmetic issue to the mother. طيب. Example of this pigmentary change is melasma, previously known as chloasma gravidarum or pregnancy mask. Chloasma in Greek, it's meant to be green, which is not described this condition, while the melasma means brown discoloration. تمام. It's a butterfly pigmentation appears on the cheeks and above the upper lip. In most cases, it appears gradually few months after delivery. Linea nigra, it's a dark line extending from umbilicus to the symphysis pubis. It appears in the second trimester. In this picture, the midline is linea nigra, and laterally, right and left sides, these marks, it's a striae gravidarum. Striae gravidarum, it's a stretch mark specifically developed during pregnancy. There is many types of stretch marks occur in many conditions a part of pregnancy. Example in Cushing syndrome, rapid weight gain, and patient with edema. These types of stretch marks. We concerned about striae gravidarum, which is occur in pregnancy. Predominantly found in the abdominal wall below the umbilicus due to the growing uterus. Can found also in breast, thigh, and buttocks due to weight gain. Range from red and purple to white in fair colored people, but be dark brown as in the last picture. Regarding breast change during pregnancy, the breast enlargement occur due to both mechanisms, hypertrophy and hyperplasia, mainly under effect of estrogen and progesterone, but other hormones involved is human placental lactogen and prolactin. A part of enlargement, there is increased pigmentation of nipple and primary areola. First pregnancy specifically, the appearance of secondary areola. Regarding cardiovascular system, there is increase in cardiac output by 40% in pregnancy. As we know, cardiac output as equation is a product of stroke volume by heart rate. The increase in cardiac output mainly due to stroke volume rather than increase in heart rate. Stroke volume in pregnancy increase about 30%, whereas heart rate increase approximately 10%. So, cardiac output increased by 40%, stroke volume by 30%, heart rate approximately 10%. تمام. Blood pressure, which is a product of cardiac output by systemic vascular resistance, is decreased in pregnancy by 20 to 30% in spite of increase in cardiac output. The decrease in blood pressure is due to smooth muscle relaxing effect of progesterone, nitric oxide, and prostaglandin on systemic vascular resistance. There is overall decrease in diastolic blood pressure and mean arterial pressure by 5 to 10 millimeter mercury. In supine hypotension syndrome, during late pregnancy, when the patient is lying in supine position, the cavity uterus will compress the inferior vena cava, and the inferior vena cava compressible and the aorta will be affected. This compression of inferior vena cava will compromise venous return to the heart, produce the effect of hypotension, tachycardia, and syncope. The blood pressure will restore by turning the patient to the left lateral position. These cardiovascular changes in pregnancy in summarize the table. Regarding ECG, electrocardiographic change, the increase in cardiac output in pregnancy cause hypertrophy and dilatation of left ventricle and left atrium. The upward displacement of the diaphragm by large uterus will shift the axis of the heart anteriorly and to the left. So, the typical features of ECG in pregnancy is sinus tachycardia and left axis deviation. Regarding the respiratory system, as we mentioned, the enlarged uterus will elevate the diaphragm, decreasing the total lung capacity by 5%. In spite of this reduction, ventilation will increase by 40% due to stimulation of respiratory center by progesterone. To produce this hyperventilation state, the reduction in total lung capacity will be compensated by increasing tidal volume and respiratory mid volume. As you know, tidal volume is the volume exchange during normal respiratory cycle, while minute volume is total volume of gases exchanged per minute. تمام؟ Vital capacity unchanged, but residual volume decreased, leading to reduction in expiratory and inspiratory reserve volume. Chest wall compliance will decrease due to drying size and breast hypertrophy, but the lung compliance, which is the ability of the lung to expand, doesn't change. Respiratory rate in resting position will not change. In spite of that, 70% of pregnant women have subjective dyspnea وعند إحساس بالshortness of breath. This illustration demonstrates some terminologies used. As we notice, total lung capacity equal vital capacity and residual volume plus residual volume, while the vital capacity involve inspiratory reserve volume, expiratory reserve volume, and tidal volume. During pregnancy, total lung capacity decreased by 5%, vital capacity unchanged, inspiratory, expiratory, reserve volume, and residual volume will decrease while the tidal volume will increase by 40%. تمام؟ Regarding acid-base balance, as a result of hyperventilation, there is decrease in partial pressure of carbon dioxide. These facilitate transfer of carbon dioxide from fetus to mother. As the carbon dioxide cross the placental barrier by passive diffusion, which is dependent on concentration gradient difference, the decrease in partial pressure of carbon dioxide on maternal blood will facilitate transfer from fetal side to the maternal side. Then this carbon dioxide will be washed out by the maternal lungs. There is rise in pH with end result of respiratory alkalosis. This respiratory alkalosis will be compensated by increased renal excretion of bicarbonate. So, the acid-base imbalance in pregnancy demonstrated as respiratory alkalosis. Urinary system. In pregnancy there is kidney hypertrophy and dilatation in collecting system and ureters due to effect of progesterone. There is also a mechanical factor contribute to this ureteral dilatation. demonstrated by hydronephrosis, mainly in the right side due to right dextral rotation of the uterus. As a consequence, the dilated collecting system holds 2 to 300 ml of urine, which is act as a reservoir for bacteria and risk of ascending infection. Both renal blood flow and glomerular filtration rate will increase in pregnancy. Gastrointestinal tract. Nausea in pregnancy known as morning sickness, vomiting or emesis gravidarum, both a common complaint in pregnancy, occur mainly in early months, explained by increase in progesterone and human chorionic gonadotropin. Also, progesterone has effect on esophageal sphincters, which relax these sphincters and lead to acid reflux. As we mentioned, progesterone عنده relaxing effect على smooth muscle صح؟ This is lead to delayed gastric emptying. As a consequence of delayed gastric emptying and relaxation of esophageal sphincter, which is lead to risk of reflux and aspiration pneumonia. Also, progesterone will decrease motility in small and large bowel and result in constipation as a consequence. Some patients complain of dyspepsia, which is explained by decreased contractility of gallbladder. As a result, pregnant women more prone to develop gallstone during pregnancy. In summary, for gastrointestinal tract symptoms, nausea and vomiting due to effect of HCG and progesterone. Progesterone effect on gastrointestinal tract. First, increase risk of acid reflux, decrease the gastric emptying time, decrease small and large bowel motility, decrease gallbladder contractility, and dyspepsia and gallstone as a consequence. تمام. Carbohydrate metabolism. Pregnancy is a state of both enhanced beta cell function and insulin resistance. Beta cell هي pancreatic cells produce insulin صح؟ why؟ لأنه في insulin resistance peripheral في التشو في insulin resistance. insulin resistance سببه شنو؟ mediated primarily by placental secretion of diabetogenic hormones. These steroid hormones, mainly estrogen, progesterone, and corticosteroids, antagonize the effect of insulin peripherally. تمام. Also, insulin destroyed by placenta and kidney. Last lecture قلنا placenta عندها many enzymes منها الانسولينيز صح؟ insulinase extract insulin and kidney secretes the insulin from the body. As a result of peripheral tissue insulin resistance, there is a maternal hypoglycemia. This mechanism ensures continuous supply of glucose to the fetus. As the glucose crosses the placental barrier through the facilitated diffusion, which is dependent on concentration gradient. So maternal hyperglycemia, it's necessary to maintain this supply of glucose to the fetus. Okay? Hematological system. In pregnancy, blood volume expands by 40 to 50% above non-pregnant level, while RBC's mass will increase up to 20 to 30%. This disproportionate increase between RBCs and plasma will produce a state of hemodilution known as physiological anemia. Even this physiological anemia has many advantages. Advantage of this relative hemodilution to decrease blood viscosity and ensure optimum gases exchange between maternal and fetal circulation, protect mother against thromboembolic disease, and protect mother from effect of blood loss during delivery. Regarding leukocyte count, there is physiological leukocytosis. This leukocytosis is result from pregnancy itself as a stress state, which is induced by systemic inflammatory response, lead to production of leukocytosis, with subsequent peak after delivery due to childbirth stress and tissue trauma effect. This is considered protective mechanism and support tissue healing process. The platelet count usually remain constant, but around 6% of women develop gestational thrombocytopenia. طيب to differentiate الجستيشن thrombocytopenia من الاميون تايب thrombocytopenia زي ال ITB. الجستيشن thrombocytopenia benign condition occur mainly قلنا في second half of pregnancy, will not affect the baby, ما بكون عنده neonatal thrombocytopenia and resolve spontaneously after delivery. حتى بتكون moderate thrombocytopenia، بتكون severe، بتكون less than 50. تمام. So it's a benign condition, self-limiting, not requires treatment. Iron metabolism. Iron is absorbed in ferrous form from duodenum and jejunum and released in circulation as transferrin. So ferrous is the absorbable form of iron. تمام. والtransferrin هو الglycoprotein، هو main transporter protein of iron في circulation, responsible to transport iron to various tissues. تمام. Iron freed from transferrin and incorporated into hemoglobin mainly and myoglobin or stored. Storage form ferritin هو main storage form of iron or hemosiderin. Difference between hemosiderin and ferritin: hemosiderin insoluble and visible بالelectron micron ما زي الفيريتين. فالstorage form ferritin mainly or hemosiderin. والabsorbable form هو الفيرس، والtransport بيكون through transferrin. Iron is transported actively across the placenta to the fetus. Active transport means against concentration gradient regardless of maternal ferritin level or hemoglobin level. There will be active transport of iron through the placenta. So no correlation of hemoglobin concentration between mother and fetus. Consequently, iron deficiency anemia is the commonest hematological problem in pregnancy. Hypothesis in pregnancy. Pregnancy is known to be hypercoagulable state. This is due to increased coagulation factors production and decrease in fibrinolytic activity. And this is beneficial in the third stage of labor to control bleeding after placental separation from the placental bed. As we know, placenta occupy 30% of uterine wall, صح? Last lecture. So this hypercoagulable state will be a protective mechanism from postpartum hemorrhage. Implications on therapeutic drug administration. How physiological change can affect drug administration and metabolism. First, absorption of drugs from gastrointestinal tract may be impaired by gastric stasis, poor gut motility, and some drug by lower gastric pH. احنا قلنا البروستيرون بيعمل شنو؟ بيعمل delay gastric empty و delay للsmall and large bowel motility، صح؟ So absorption will be affected first. Second, increase in plasma volume will decrease drug concentration. Also, increase in glomerular filtration rate will increase drug excretion, which is mainly secreted by kidneys. In summary, drug absorption and concentration will be decreased with acceleration in renal excretion. These changes require doses to be adjusted in pregnancy. Lastly, musculoskeletal system. As pregnancy advances, the gravity center will shift anteriorly, resulting in lordosis and backache. As effect of progesterone and relaxin, there is increased mobility of the pelvic joints and softening of ligament. Relaxin is hormone produced by ovaries and placenta, prepare ligaments and pelvis for birth process. The pubic symphysis and sacroiliac joints particularly affected by relaxin. This ligament laxity will affect lower limb biomechanics and further affect in gait, pelvic stability, and result in pain. Last objective in this lecture: physiology of lactation. In pregnancy, there is hypertrophy and hyperplasia of alveolar cells and lactiferous ducts, صح؟ as we mentioned, due to estrogen, progesterone mainly, and hemoplacental lactogen and prolactin also. During pregnancy, the high level of estrogen and progesterone hold lactation process and milk production achieved only after delivery when the progesterone and estrogen level drop. To understand physiology of lactation, we'll talk about prolactin and oxytocin. Prolactin is a polypeptide hormone released from anterior pituitary controlled by prolactin inhibitory factors from hypothalamus. The most important prolactin inhibitory factor is dopamine. So, dopamine agonists will suppress milk production and dopamine antagonists will stimulate prolactin production. Prolactin secretion is stimulated by suckling stimulus, which send afferent impulse to the hypothalamus and lead to surge of prolactin release. So, prolactin is polypeptide hormone released from anterior pituitary gland under control of hypothalamus, inhibited by dopamine and stimulated by suckling reflex. Suckling also stimulates oxytocin release, which is octapeptide hormone produced from hypothalamus, particularly supraoptic and paraventricular nuclei, and stored in posterior pituitary gland. So, production from hypothalamus and storage in posterior pituitary gland. Effect of oxytocin: it's bind to myoepithelial cells around alveolar cells and lactiferous ducts. As a consequence of contraction with these myoepithelial cells, the already produced milk by effect of prolactin will be ejected. So, both prolactin and oxytocin are necessary for successful breastfeeding. In general terms, prolactin stimulates production of milk, while oxytocin stimulates its ejection. تمام يا شباب. By this we reach the end of the lecture. Good luck. Thank you.